or in the chat and we'll respond to you.
Can you see my slide, please?
Yes, go on slide mode, please. Good.
Let me shut my door. I think it's better.
Dorothy, please, we have participants here now. You might want to regulate the conversation.
Right. Welcome, everybody. We can see participants joining. We'll give a few minutes for everyone to set in, and then we'll kick off the webinar. Bonjour à tous et bienvenue à ce webinaire. Nous allons commencer dans quelques minutes, s'il vous plaît. Je vous prie de garder à l'écoute et on va attendre tout le monde. Okay, we'll begin in a minute. I can see there are no longer people joining. I think they will join us as we go along. Nous allons commencer dans quelques minutes, s'il vous plaît. Right. So good morning, good afternoon, everyone, partners and colleagues, and welcome to this webinar, the webinar on dengue outbreak control in the African region. I am very honored to have all of you in this very interesting webinar. I am Dr. Achu Dorothy. I am team lead for the tropical and vector-borne diseases in the WHO African Regional Office. And I'm also lead for the incident management team on dengue for the region. So it's my pleasure to welcome everyone. This webinar is going to take place for 5 days, from today to Friday at the same time. We invite everybody to register. As you're seeing your screens, you have two options to register. You can register by clicking the register icon, or you can scan using your phones and register through Zoom. We have the webinar is going to take place in 6 sessions over the next 5 days. The agenda, we will go very quickly. There'll be a session on dengue risks, clarification, case definitions, and diagnosis today. Tomorrow, we'll be looking at the clinical management of dengue in children and clinical management of dengue in adults. And then on Wednesday, the 28th, we'll address integrated surveillance of dengue and dengue vector surveillance. On Thursday, we'll have 2 sessions as well: integrated vector management and dengue emergency response. And on the last day, we have the management of dengue outbreaks and risk communication, community engagement. So the objective, as you would have imagined for this workshop, for this webinar, is really to build capacity of our member states in dengue control, dengue outbreak control, in all these aspects that I named before, giving you the latest guidance available and the tools that you can use in addressing dengue in the countries. We've invited the 15 countries that are currently endemic in the region, but also other countries in the region that are at risk of having dengue outbreaks. So we can address the problem not only as outbreaks, but also in a proactive nature, integrating dengue control in our routine programs and surveillance systems. So to do this, we will give you a few other household tips and guidance. Apologies, I'm having a sticky screen. First of all, the interpretation. The webinar will be in French and English and Portuguese. But before we start, note that this virtual training adheres to the code of conduct to prevent harassment, including sexual harassment at WHO events. So be aware of your comments and your reactions that could affect others. For the questions and chats, you have the bar on the top of your screen. Some of you have it at the bottom. You just have to use the question and answer icon for your questions that are related to the presentations. But if you have any challenges, logistic challenges, or you want to introduce yourself, because we wouldn't have opportunity to introduce everybody, then you can use the chat box, which is also on your screens. As I mentioned before, we have interpretation in English, French, and Portuguese. And to have access to that, you just have to click the interpretation button at the bottom of the screen, for most of you. And then you choose the language which you want to hear. You can mute the original audio if you have interferences. The live transcription, for those who want to follow the live transcription, you can also click on show captions, and then you will see the transcriptions. And you can also hide them if you don't want to see them. using the right buttons. So most importantly, this session is being recorded, and we take your attendance as consent to be recorded. And these recordings will be shared at the end of the session. We'll also share all the session materials, including presentations, to participants during the days following the webinar. And at the end of it, we'll also like to have your feedback, which is very important for us to improve the way we conduct these webinars and to restructure future sessions so that they can meet your expectations. So lastly, I would like to introduce today's sessions. I'm having a sticky. Right. So for today, we have an agenda which is very full, so we'll appreciate keeping of time. We have 6 presentations, one on the global epidemiology and burden of dengue from Dr. Rahman Velayudang from the NTD program in Geneva. We'll have another presentation on the epidemiology of burden of dengue in the WHO African region from Dr. John Ochdiema from Afro, and then one on dengue risk classification in WHO Afro from Dr. Boris Pavlin from WHO Geneva, Switzerland. So following that, we'll have questions and session answers. And please, while the presentations are going on, you can type your questions in the Q&A box so that presenters can respond to them as we go along. The second session will be on case definition and diagnosis. And we will have 3 presentations: dengue case definitions from Dr. Diana, from the WHO Health Emergency Program at WHO headquarters, Geneva. Another presentation on pathophysiology of dengue, Dr. Emilie Javel. She's going to be speaking in French from France, from the Armed Forces Biomedical Research Institute. And then one on dengue diagnosis and differential diagnosis for dengue from Dr. Konungoi Limbaso from the Kenya Institute of Medical Research. So with that, dear participants, we look forward to your very assiduous participation and keen attention as we go through these sessions. Thank you very much, and we'll begin with Dr. Rahman. Over to you. You have 10 minutes. So while Dr. Rahman puts up his slide, please send your introductions in the chat box. Over to you.
Can you see my slide?
Yes.
No, Dr. Rahman. We
no?
cannot. No, we cannot. Please keep the slide mode.
Yeah.
Please.
It is on slide mode again.
Okay. Keep it on slide mode. Please
Yeah.
stop sharing. Stop
Yeah.
sharing. Then go to the share screen button and then choose the screen where the slide mode is. You have screen 1 and screen 2. When you
Yeah.
click on the share screen, you have screen 1 and screen 2. Share the screen where the slide mode is.
Okay. Let me share. No, it is not working again. Can you project it from your end, please?
Yes, please, Amarachi, can you share?
Yeah, thank you.
Slide mode, please.
Great.
Thank you very much. Sorry for this delay. So basically, my topic is on the epidemiology and burden of dengue. Next slide, please. So the dengue is found in all tropical and subtropical areas worldwide, mostly in urban and semi-urban areas. There we estimate around 400 million cases annually, and around 4 billion people in 130 countries are at risk. Now, I have excluded mentioning Afro because John will cover that. But this graph on my right side clearly shows the threat of dengue in many parts of Africa, especially the dark brown region, are all known to have experienced dengue since 1960s. Climate change and urbanization favors the development of both the vector and the virus. Next one, please. So around, as I said, 4 billion people in 130 countries are at risk, and mostly these are Aedes-borne diseases. Actually, we have 4 diseases transmitted by Aedes, which includes chikungunya, dengue, yellow fever, and Zika. So this is a map which has been developed by WHO to just show the threat globally. Next slide, please. So basically, our global response to this strategy is based on the Global Vector Control Response, the NTD roadmap, the Global Arbovirus Initiative, and we are also aware of the framework of integrated control, elimination, and eradication, which was approved by Afro Regional Committee in 2022. Next one, please. So in case of Global Arbovirus Initiative, we have 6 pillars, which is basically aspects like monitoring risk and anticipating outbreak, reducing epidemic risk, strengthening vector control, prevent and prepare pandemic, enhance innovation and new approach, and building a coalition. Now, this strategy is a joint collaboration between emergency as well as the neglected tropical disease department, but we are having other partners too, and we follow the One Health approach. Next slide, please. So in terms of global trends, as you can see, dengue has been the highest number of cases was reported way back in 2019. And during the pandemic, we had dengue right through 2020, 21, and 22. So there is in 2019, we had more than 500,000 cases reported from 110 countries. Next one, please. So the deaths also followed the same pattern. We had about 5,800 deaths in 2019. Next one. So what has really changed now is that in 2023, we really had a huge increase affecting all 6 WHO regions. We have tentatively, our numbers are approximately 6 million cases, over 6,000 deaths affecting 92 countries. The most affected, of course, are Brazil, Bangladesh, Mexico, Peru, Burkina Faso, and so on. Next one, please. So this is just to give you a brief update that Brazil and Peru had a high number of cases in the Paho region. In Wupro region, it was Philippines, Vietnam, and Cambodia. And in CRO, it was Bangladesh, Thailand, followed by India. And still we are getting more reports, so the figures will be updated. Next one. Next slide, please. Next slide, Amarachi, please. Yeah, so next slide, please. Just click. Okay, so in the Eastern Mediterranean region, also we had dengue in Somalia, Pakistan. But more interestingly, for the first time, we had high number of cases, more or less, in Europe with Italy, France, and Spain reporting local transmission. And of course, as I said, the Afro part will be covered by Dr. John later. But we know that Burkina Faso had the highest number of cases. Next one, please. So just to introduce from a human perspective, dengue is a flu-like illness, but occasionally develops more potential lethal complications, which we call severe dengue. Over 80% of the cases are asymptomatic. There is currently no specific treatment for dengue, but early detection and access to proper medical care lowers the fatality. Actually, most of the countries are reporting less than 1%. Public health control largely depends on vector control, and currently there is only one vaccine available. Next one. So from a virus perspective, it is a flavivirus. It is the same genus as Zika, yellow fever, and West Nile. There are 4 distinct serotypes of dengue. So this is complicating things. So they are very distinct serotype. If you are affected by one, you have a lifelong immunity against that, but there is no cross immunity. There is only a partial immunity, which is temporary. So the chances of you getting a second infection is always there, and subsequent second infection, which we call secondary infection, can lead to severe dengue. So dengue is mosquito borne and it is transmitted by Aedes aegypti and Aedes albopictus. Next one, please. So from a vector perspective, you have 2 vectors, Aegypti and albopictus. Aegypti basically originated from Africa, but has spread throughout the tropics. Albopictus is more Asian origin, and it has spread to the American region, Africa, and even Europe, starting in 1985. Next one. So what is clear about these 2 mosquitoes is these are clear distinction from malaria, and we need to take note of this. First of all, the egg can remain dry for many months and hatch when it comes in contact with water. In terms of control, we need to address both immature and the adult stage. They are both day biters and can bite you both at home, place of work, and at school. And they prefer, especially Aegypti, prefers to bite several people in one go. So it is not satisfied with one single bite, but it tries to fill its stomach with several bites. So this is another challenge because that leads to clusters of cases. Next one. So these are the factors which led to global spread of Aedes. 1, urbanization, a large clustering of houses, huge dumps of used tires. They like to breed in tires which has very little water, and then of course solid waste. Next slide, please. So it can also breed in flower pots and as well as in the axils of leaves. As you can see, banana plantations or any axle where there is a small quantity of water that is adequate for Aedes to breed. Next one, please. So the challenge for burden of the dengue is that we are really, as I said, 80% are asymptomatic. So we are not seeing the full picture of dengue. And what you see is the top half. You can see the severe dengue, some cases which report to clinics, and of course the death we can tabulate. But there's a whole big amount of self-medicated dengue, which is the lower part, the self-managed dengue and inapparent dengue, which cannot be detected. Next one. So we really need to do burden estimation. For example, this is just to give you an example of a country. They reported 2,700 cases in 2017 and 10,000 cases in 2018, but their true burden is far, far higher. Their death, severe dengue, and the real number at the country community level runs to millions. So this is a challenge. Next one. So basically, WHO has developed a toolkit which you can download and use. And actually, the first paper has been published based on the toolkit. And this helps you to estimate burden. And every country, we encourage them to do burden estimation. And if you need training programs, we are happy to do that. Next one, please. So vector control, as I said, it did all the conventional vector control methods, both chemical and non-chemical methods can be used, but the body of evidence for vector control is rather weak, and we are trying to develop better evidence base for most of these vector control measures. Personal protection is definitely recommended. Next one. So here are several tools which are currently under development. One is targeted indoor residual spray for dengue, which is well known. Spatial repellents are under evaluation, almost similar to malaria. We have several traps which are currently under evaluation. There is also a sterile insect technique which is under study. The Wolbachia-based population alteration method is currently has completed a randomized trial, and we are currently working on its guidance document. And then, of course, we have Wolbachia, a suppression model, which is also starting their trial in Singapore. Next one. So in terms of dengue vaccine, we only have one vaccine, which is now called Q-Dengue, and has been approved for use in age group of 6 to 16 in high transmission setting. This vaccine is now being introduced in few countries. Right now in Brazil, they are vaccinating about 3.2 million people. Next one. So the way forward is to have regional arbovirus initiative, integrate with other arboviruses. We need capacity building at regional and country level. Diagnostics also needs to be built. Surveillance have to be improved. We can do integrated surveillance wherever possible with malaria program, improved case management, and as I said, more sustainable tools are in the pipeline. Next one. So climate change is definitely going to cause high increase in dengue. There will be climate refugees and movement of vectors. Increased urbanization, especially in Africa, is again a big challenge. But I think based on the lessons we have learned from COVID, we must utilize the COVID platform and approaches to enhance diagnosis, enhance surveillance, effective communication methods, and involvement of the community. We also need to include gender equity and human rights issues and carry out burden estimation periodically. Next one, please. So basically, we have to foster multi-sectoral collaboration, reorient vector control program wherever needed, a shift to integrated surveillance. We need to clearly monitor the impact of climate change, promote effective communication, and vaccine and vector control may work together, and innovation in health system and integration of the program is the way to go. Next one. Thank you very much. Apart from the Q&A, if you have any Q&A, please feel free to ask. And of course, you can email me, and this is my email. Thanks a lot.
Thank you so much. Thank you very much, Dr. Rahman. Over to the next presenter. The slides are down already. Thank you. Please send in your questions. And we'll invite Dr. John. Please take the floor to speak to us about the African region.
See my screen, please?
Yes.
Okay, I will be presenting in French. My slides are written in English, so it will be easy to move forward. I will be presenting je vais présenter la situation de la dengue dans la région OMS Afrique. L'objectif de cette présentation est de vous donner une vue générale et une estimation de l'ampleur de la dengue dans la région OMS Afrique. Comme vous le savez, la dengue en Afrique est sous-estimée. Même le nombre de cas, comme Dr Rahman vient de le dire, ce qui est rapporté et de loin représente la réalité. Ce n'est que le sommet de l'iceberg que nous sommes en train de voir. Et en 2020, il y avait une revue systématique qui a été organisée, une étude qui a été menée et qui avait estimé la prévalence de la dengue à 29% pendant la période d'épidémie et une prévalence de 3% dans les périodes non en épidémie. Et il a été rapporté qu'en Afrique, le sérotype 1 et 2 représentent plus de 60% de l'ensemble des épidémies qui ont survenu à la dengue. Il faudrait noter que la densité de la population des AEDS est sans cesse croissant. dans la région Afrique. Un élément important à souligner ici est que les erreurs de diagnostic, les diagnostics erronés de la dengue, partant avec la confusion des autres maladies fébriles, notamment le malaria, le paludisme, c'est un problème assez récurrent en Afrique et du fait de l'insuffisance de formation et puis même l'état, le tableau clinique même de la dengue prête à confusion et amène à des diagnostics erronés. C'est parmi les choses qui caractérisent la dengue au niveau de la région africaine. Il est important de mettre en place un système de surveillance, mais aussi maintenir ce système de surveillance pour les maladies fébriles en général. Comme Dr Raman a dit, il s'agissait de renforcer, avoir un système intégré des maladies fébriles en général dans la région Afrique. Ici, ce slide vous montre les facteurs de risque de la dengue. Dr Raman l'a parlé rapidement, mais au niveau de la région Afrique, sur une étendue de 25 études, il a été démontré qu'il y a l'âge avancé était un facteur important à considérer sur le plan socio-démographique, mais aussi les insuffisances de la lutte antivectorielle. L'urbanisation, c'était un autre facteur qui a été identifié. Le facteur de changement climatique, mais aussi l'histoire récente de voyage dans une zone en épidémie ou endémique, et puis le type d'occupation, le niveau d'éducation, les revenus faibles et autres facteurs ont été identifiés comme facteurs de risque de la dengue dans la région africaine. Entre 2017 et 2023, il y a eu au total dans la région OMS Afro 51 épidémies de dengue qui ont été rapportées avec 195 882 cas et plus de 745 décès. Et ils ont été rapportés de manière quasi systématique dans 25 pays d'Afrique. Comme vous le voyez, ce qui est caractéristique et ce que nous retiendrons à travers ce slide, Dr Raman a montré que sur le plan global, c'est beaucoup plus l'épidémie de 2019 qui avait rapporté plus de cas, mais dans la région d'Afrique, c'est en 2023 qu'on a rapporté le plus grand nombre de cas. Comme vous voyez, le schéma est assez clair, comme vous le voyez, le nombre de cas est 8 fois plus par rapport comparé à l'année 2019. Et en 2023, cette épidémie qui continue en 2024, s'il faut prendre les 6 dernières années, l'épidémie de 2023 compte à elle seule 80% des cas et 91% des décès. Présentement, au 8 mars, au 18 février 2024, nous avons répertorié 217 805 cas de cas suspects de dengue et les cas confirmés étaient autour de 98 000. Le nombre de décès était de 799 décès enregistrés dans 15 pays de la région OMS Afrique. Et je crois que vous êtes en train de voir la liste des pays qui ont rapporté au moins un cas. Et ça, ce sont les détails. Dr Raman l'a dit, le Burkina Faso est le pays le plus touché qui compte à elle seule 75% des cas et 91% de décès enregistrés dans la région OMS Afro. Mais actuellement, le Burkina Faso est en train de faire des efforts et l'épidémie est quasiment contrôlée à ce stade. L'IMS, au niveau du gouvernement du Burkina Faso, a été désactivé. Sur les 15 pays, 8 pays sont encore en train d'expérimenter les rapportés des cas de dengue qui restent actifs à ce stade ici. Je crois que vous êtes en train de voir les 8 pays qui ont rapporté en 2024. C'est la partie droite de votre tableau. Ça, c'est juste pour voir comment l'épidémie de 2023-2024 a évolué sur le plan temporel. Le pic a été enregistré autour de la semaine 43, 44, mais maintenant, là, nous sommes en train d'observer une chute progressive. La carte qui se trouve à votre gauche montre les pays afro qui ont rapporté les cas et les décès au cours de l'épidémie de 2023-2024. Il s'agit essentiellement, je vais le répéter, 15 pays au total qui ont rapporté sur les 47 pays qui comptent la zone afro. Ce graphe vous montre un peu les tendances comme il a été. Comme nous avons dit, la plupart des pays ont connu le pic autour de la semaine 44. Le Burkina Faso, la tendance est vers le bas. Et il y a également Sao Tomé et Principe, et même le Sénégal. Et puis Cap-Vert, au milieu, vous êtes en train de voir, et le Mali. Le Cap-Vert, c'est un peu un plateau, autant que le Mali. Mais l'un des pays que nous sommes en train de suivre actuellement, c'est l'île Maurice. Et vous êtes en train de voir les nombres de cas rapportés et de manière croissante dans ce pays que nous avons. Quelques activités qui ont été au niveau de l'OMS Afro. Premièrement, il faut noter que l'OMS Afro a installé un groupe d'experts venus de différents classeurs, un groupe pour gérer, appuyer les pays dans la gestion de l'épidémie au niveau zone afro. Nous sommes en train de développer des guides de préparation et de réponses. Et ça va être diffusé très bientôt en langue française, anglais et portugais. Et l'OMS aussi appuie le déploiement des épidémiologistes, des laborantins et des experts en contrôle vectoriel. Et nous avons mobilisé des fonds, plus d'1 million de dollars jusqu'à présent, mais qui ont servi à 6 pays que nous sommes en train de faire. L'OMS a développé un mapping, une cartographie de risques. Et c'est mon collègue qui vient après moi qui va présenter la cartographie des risques de la dengue dans la région africaine et qui va aller, mais aussi nous sommes en train de développer le plan de préparation et de réponses, toujours pour accompagner. Nous collaborons étroitement avec d'autres organisations gouvernementales, notamment ECOWAS, avec eux, nous avons organisé plusieurs séminaires et les assister. Nous avons plusieurs produits que nous sommes en train de diffuser, notamment les sites web régionales. Chaque mois, nous publions la situation de la dengue dans la zone Afrique. Il faudrait dire rapidement que, comme on l'a dit, le nombre de cas rapportés est de loin sous-estimé pour des raisons que Dr Aman l'a dit. Il y a des soucis sur le plan des budgets, mobilisation des budgets, mais en termes de ressources humaines et d'expertise, il y a le manque, l'insuffisance des experts en contrôle des vecteurs et des entomologistes dans la région. C'est pourquoi il faut penser à un plan de renforcement des capacités et aussi d'autres challenges liés à l'acquisition de commodités. Et notre priorité actuellement par rapport à la situation, c'est mobiliser plus de fonds, renforcer les capacités, continuer à appuyer les pays qui continuent à avoir une transmission active de la dengue dans ce pays-là, finaliser le plan de préparation et diffuser tous les guides techniques que nous sommes en train de faire. Et comme on l'a dit, nous sommes en train de travailler avec le siège pour mettre en place un système de surveillance intégré et qui va avoir un dashboard dynamique qu'on peut checker la situation de la dengue dans la zone Afrique de manière permanente. Nous devons aussi adresser les défis que nous avons évoqués si haut. Merci beaucoup de nous avoir suivis. Nous sommes là à votre disposition au cas où il y a des questions. Over.
Thank you very much, Dr. John, for completing the first presentation. Just to mention that Dr. John is also the incident manager for dengue for the WHO African region. And of course, most of the countries have been interacting very closely with Dr. John. Thank you so much. We will go now to what he announced already as the third presentation on dengue risk classification in the WHO African region. I think it's specific because each region tries to adapt their approach in classifying risk. So this will be presented for us by Dr. Boris Pavla from WHO, Geneva. Over.
Great. Thank you, Dorothy, and hello, colleagues. As indicated, I'll be presenting about the country risk categorization for the African region. In December, WHO globally declared dengue to be a grade 3 emergency, our highest level. And as part of that response, we are undertaking these exercises to understand which countries are at highest risk. So this identifying the high-risk countries is important for our prioritization of technical support to which countries, as well as for partners to understand where. It's for our efforts at resource mobilization. And also, as John mentioned, we are setting up a global dengue surveillance system. And some countries that are perhaps not reporting now, but are considered to be high risk, would need to be supported to begin more continuous reporting of their dengue situation. As most of you will know, the definition of a risk is that it's the intersection of the likelihood of something happening and the consequences of that thing happening. So when we put that in the context of dengue, we need to measure how likely dengue is to occur in a given place. The first point is whether dengue has been obviously reported as circulating. Have there been outbreaks in the past, if there aren't now? And if there is no dengue reported, perhaps because the surveillance system isn't designed to capture it, are there Aedes vectors present? If there aren't, then we're really not that concerned. Although there may be a few imported cases from time to time, these will not lead to major morbidity and outbreaks. And further, are the environmental conditions suitable for dengue virus transmission, which goes beyond the simple presence of Aedes mosquito? On the consequence side, how consequential is dengue in a given country? We have to look at the country's overall resources or resource limitations and how vulnerable the populations are, and whether there has been historically evidence of a health burden due to dengue, which we will categorize momentarily as the disability adjusted life years. And finally, whether or not there is a considerable dengue burden present, if the country has sufficient capacity to respond to dengue, then we need less emphasis on that country in terms of the support provided. So some countries have very high dengue burden, but are very sophisticated in their dengue responses, and so it is of less support is required. For the African region, we undertook this exercise using first the likelihood indicator, which is called the U.S. Centers for Disease Control and Prevention level of risk. This is based on their assessment of frequency of dengue occurrence or evidence of past sporadic occurrence versus no evidence. Then we looked at where there had been outbreaks in let's say the previous decade before the last 2 years. And if there had been distant outbreaks time-wise, we gave that a lower risk than if they were more recent. Then we looked specifically at the last 2 years, and if there had been an outbreak during that time, this was consequential, but if it was still ongoing, that was even higher consequence. And then finally, for the last one is called the Index P, which is a virus transmission suitability index. And this was assessed at the country level, although there are subnational details beyond the country level. We aggregated at the country level for this assessment. Then when we looked at consequence, we went first to the Inform Index. The Inform Index is an overall vulnerability index that measures various hazards as well as socioeconomic vulnerabilities and vulnerable groups, as well as government coping capacity or lack thereof. And this is all aggregated into a single index number called the Inform Index, which was used for one of our consequence indicators. We then looked at the disability adjusted life years due to dengue. These are projections based on existing data that are conducted on a relatively frequent basis every few years. And we grouped them into two types of DALYs. The overall DALYs, which show the total burden due to dengue in high burden countries that are large and have large populations affected. But also looked at the DALYs per 100,000 population, which is more reflective of the proportional burden of dengue in even small countries like the Seychelles, which has a relatively very high burden of dengue given a relatively small population. And finally, we used a recent exercise that the African Regional Office undertook, which is the arbovirus country capacity scoring, which looks at a number of different dimensions in terms of countries' abilities to respond to dengue, including surveillance, community outreach, and social mobilization, and so on. So when we put that all together, we arrived at a criticality score, which was simply the arithmetic sum of all of those 8 different risks, risk indices added together. And then as a result of that, we grouped countries into 3 tiers. Those that had an ongoing outbreak right now are all automatically tier 1, and those require emergency response. Those that were above the median score also fell into tier 2, which is the countries that require a readiness interventions. So recognizing that some countries may currently have an outbreak, but also have an underlying high risk, even when the outbreak is over, they have a package of readiness activities that are meant to be undertaken. And finally, all other countries require a certain set of preparedness activities that are outlined in the plan. When you look at the totality of this, we ended up with 11 countries in tier 1 currently having outbreaks. And then in addition to those countries which are having outbreaks, there are also those that fall in the tier 2 as being higher risk and therefore readiness, and the rest of the countries falling in tier 3. For more information on the methodology, the link is presented here. It was summarized, it was explained in detail in the first African Regional Situation Report as shown here. Thank you very much.
Thank you very much, Dr. Boris, and especially for making us gain a few more minutes. So, colleagues, we have had our 3 first presenters. We will want to take a few questions and answers. There's already some in the Q&A box, but really to say that from the messaging, all countries in the region are affected or concerned by this problem. It's an emerging problem in the region, and there could be outbreaks in different countries. It appears seasonally. We can see countries that get into outbreaks and out of outbreaks, but whatever the case, we have to really make sure each country knows their classification and puts together the set of activities that are appropriate for their classification of risk. So thank you for these. We're going to take quickly the questions in the Q&A. We have 4 of them. I hope can you put up your hands, please? You can indicate by show of hand. I think it's going to be very difficult for us. Go to the reaction. If you can want to speak up, you can go to the reaction button at the bottom of your screen where you have three dots, and then you click on reactions, and then you put up your hand, indicate your hand, and then we will give you the floor. But while waiting for people to indicate, let's answer those questions that are already in the Q&A. So I'll get the first one coming from Gemechu Feisa. Is there any research support funding or logistics in terms of reagents or test kits to those working on dengue research from the WHO side? And is there any collaboration she's working on, or he's working on dengue research. So, John, can you help answer that question? And how can we, the second one will be addressed by Dr. Rahman. How can we eradicate vectors in the African region? And there is a third one. Is there any sequencing work ongoing for regional data for better understanding of any evolution? So serosurveillance in that case, or sequencing. Again, Dr. Rahman or John, you can come in. And then there's a last question on explaining the difference in Burkina Faso and the neighboring countries. Why is there a difference? And whereas they have the same risks in terms of the environment and the human populations. So I think there is another question on the from Dicia on the upsurges for malaria as well. Quelles sont les mesures à prendre? Okay, so this is one on malaria. We are talking, this webinar is on dengue, but we can also appreciate the importance of approaching this in an integrated manner, integrated disease surveillance, integrated fever management. However you look at it, we are talking about vectors. And even though the vectors are different, how do we manage both in that context? So over to you. We begin with John and then Rahman.
Thank you so much for the questions, and Dr. Rahman will be adding a little bit. First of all, research is one of our pillars within the preparedness and response to dengue. So we know that we still having some unanswered questions, and even through the global arbovirus initiative, research is one of the key pillars to better understand the burden of the disease in the regions, of course. But maybe not resources are available, of course. This is why we are advocating to have more resources. Now we are putting more resources on vector control and integrated vector control and that approach. But just to confirm that there is some allocation for the research, because it's one of the pillars we identify to better understand and to better address the issue. Burkina Faso, why it's different? It depends on the surveillance capacity of each member state countries. You know, you may not, maybe it's less underestimating Burkina Faso. This is just an assumption than other countries. But the key thing is to keep in mind here, it's mainly related to the capacity of the country to detect, to have available testing strategy and commodities and surveillance system. Some countries are not just reporting cases because maybe due to the lack of commodity and others. So it will be my answer why difference between Burkina Faso and Burkina Faso is one of the example where they are doing a lot of research also. It can be also the explanation. For Somalia, we receive in the chat the answer for Somalia. Thank you. For Somalia, it's about 300 cases and 1 death reported. It will be good to share the latest CITREP with us so we can really understand the situation and can report. This is an example that some countries are not just reporting. How to control dengue in the African region? I will let Dr. Rahman jump in this question, but it's a joint effort. We are addressing dengue as just a single standalone event, but for us, it's putting the dengue preparedness and response part of the arbovirus global arbovirus initiative. So to address the dengue. So the strategy is really moving forward on one half, but taking into consideration the global adversarials with the 6 pillars. And I will let Dr. Rahman talking about the global. This is how we are putting together the effort to control outbreak. There is some sequencing studies ongoing. It's more seroprevalence is more common, but the sequencing is few countries are conducting sequencing in the regions because of resources and also, but this is something we keeping in mind. Over to you, Dr. Rahman. You can jump in. Thanks.
Thank you so much. Yeah, basically, there was a question whether the vector can be eradicated. It's not easy, to be honest. So we really can only control it, keep their density down. Of course, we can aim for final elimination when we have the tools for it. But right now, we are trying to control their population density to a low level so that outbreaks can be prevented. In the other issue on Burkina Faso and few countries which had an upsurge this year, I would assume basically that many of them are secondary cases, which I mean that maybe 2 or 3 years earlier, they had first attack of dengue, which was very mild, but later when you get a secondary attack, that is when we begin to report more cases reporting to the hospital, we have deaths and so on. So this is the secondary wave, which we have to be very careful and we need to manage them more effectively to reduce the case fatality rate. In terms of research, there is a lot of work going on with vector as well as vaccine. There are few vaccines in the pipeline. Apart from the one which is approved, we may get 1 or 2 soon. They have to be reviewed by our group, but their data is still being collected. And same with vector control. There are few tools which are coming in the pipeline like Wolbachia, sterile insect technique and so on. But again, these studies are in progress and some of these recommendations will come. What is really lacking for dengue as compared to malaria is the lack of a sustainable tool. For malaria, you have bed nets or residual spray, which can last for more than a year or 2, and sometimes bed nets can last for 3 years. We don't have that for dengue, and bed nets really don't work because this is a day-biting mosquito. So we need tools, and we are working on that. There are several tools under development, and these research can really take place even in Africa, and we are encouraging innovators to collaborate in Africa so that some of these tools can be adapted to the African context. The big challenge we have is, of course, you remember this is an urban disease, so it will hit a large number of people, and we really need to manage it effectively and with all our available tools. Case management is much more easier than malaria. We can reduce mortality to almost 0. That's what we are aiming to achieve by 2030. Over to you, Dorothy. Thank you.
Thank you so much, Dr. Rahman. I think we will give 2 minutes for the last 2 questions because it's very important before we get into case management. There are some other questions on case management in terms of integrated management of dengue and malaria, the difference between the rapid diagnostic tests. We're going to have a second session for case management in the next few minutes. But first, 2 questions one for Dr. Boris is just to clarify very briefly the main criteria for risk classification and categorization. Our French-speaking colleagues did not get it very well, so please just take that quickly again. And then the second question from Fima Nkura, he's talking about what is the place of social sciences in the policies that we are preparing to respond? What is the place for community engagement and all those soft skills that we need to make sure that people are aware and engage and address the underlying causes of transmission? And that question also either John or Roman can come back at the end before we get to the next session.
Sorry, I just need to go on to another one. So on the social science, it is included in the agenda, the RCCE component. We'll discuss elaborately on social science. So there's a whole section on it. So that's fine. Thanks.
Thank you so much. So it's considered in the strategies. So our friend female, on the 5th day, on the last day of the webinar, we'll talk more about the social sciences. Thank you. So the last minute, Dr. Boris.
Thank you. In the interest of time, I will just say that in summary, the risk classification was based on the likelihood of dengue in each country and the impact or the consequences it would have in each country. When you have a high likelihood and a high consequence, then those are the countries at highest risk. But I've put the link to the detailed methodology in the Q&A. So I would refer you to that. And if there are still additional questions, I'm happy to answer them. I've left my contact information as well. Thank you again.
Thank you very much. So colleagues, we will now move at the top of the hour to the next session so that we really keep on time. We can come back to some of these issues if you want at the end. And our second session, as we mentioned, will be on, let's put that quickly up. Now on dengue case definitions. So how do we recognize the cases of dengue? There is very similar. We mentioned before that they are viral diseases. So their symptoms are very similar to other febrile illnesses, especially malaria in the same, in co-endemic regions. So Dr. Diana will be talking to us on the case definition, and then we will move over to the next presentations before we come back to the Q&A. So over to you, Dr. Diana.
Good day, everyone. This is actually, I'm Ingrid Rabe. I am presenting on behalf of Dr. Diana Rojas, who's our team lead for Zika and Chikungunya at WHO headquarters. I would like to also mention that she will be presenting later during the week and did send apologies. She's actually en route to another dengue-related meeting at the moment. For the purposes of this talk, I'm not going to go into detail around the clinical, both the clinical features, pathophysiology, or management of dengue, because those will be adequately covered by experts presenting later. But I would encourage you, once those talks are done, to loop back and review the case definition and case classification, because it will help to integrate all of that information and to be able to see how those fit into the case definitions. So we'll start with the timeline of the guidances and classifications that have been issued through WHO and then later through the Regional Office for the Americas, or PAHO. And this slide also shows which specific severity classes are included, as well as the advantages and disadvantages of the different classifications. What I have not included in here is that the first WHO guidelines on proposed dengue classifications was published in 1974. And following that, it was revised in 1997 that was based on expert consensus. And it was a classification of dengue disease according to severity, with the categories being dengue fever and dengue hemorrhagic fever. And dengue hemorrhagic fever was then subclassified into 4 different grades. And grade 3 and 4 were defined as dengue shock syndrome. And the advantage of this classification was that it was very specific in terms of the clinical criteria. But that specificity of the clinical criteria was actually also challenging in that numerous countries reported difficulties in applying the criteria, particularly for dengue hemorrhagic fever patients, where some of the criteria required testing and capacity that was not necessarily available. And then also there were progressive numbers of patients who were having severe dengue that was not captured under dengue hemorrhagic fever classifications. And then lastly, there were also epidemiological shifts noted between pediatric and adult populations. So in light of those critiques, there was a prospective multi-center study called Dengue that was performed, and that confirmed that a set of clinical and laboratory criteria could actually be used to split patients into severe and non-severe dengue, whereas non-severe dengue was further divided into dengue with or without warning signs, and we'll look at that in more detail. And that review and additional expert panel review in 2009 resulted in the WHO classification that is still posted on the WHO website and is included in the 2009 guidelines. However, as part of that process of the review in 2009, the experts and authors did stress that there was not a lot of quantitative data and evaluation available looking at the warning signs themselves and prognostication based on those warning signs in terms of which patients will progress to severe disease. So there was a massive undertaking of evidence-based review and then a complete grade evaluation that took place in 2022 and 2023 with publication of a dengue classification in 2023. Just to mention, when looking at the advantages and disadvantages of the 2009 WHO guidance, this really was a more accessible clinical and laboratory guidance with criteria that could allow for more consistent reporting and consistent endpoints for vaccine and drug trials. But the challenges were that those data were not yet available or adequately quantitatively evaluated. That was subsequently done with the guidance that was published by PAHO last year. However, the one challenge with the PAHO guidance was that that was developed specifically for the Americas. And so based on that, we are now in the current status of doing a systematic review that's underway with a panel of experts reviewing those data following a systematic review, and that those panel of experts are regionally representative across all WHO regions at risk. So looking more specifically at the 2009 dengue severity classification, this image, which is also very closely pulled from the dengue 2009 guidance, shows the division of cases either into dengue with or without warning signs or severe dengue, where severe dengue was includes severe plasma leakage, which would lead to dengue shock syndrome, and fluid accumulation with respiratory distress, or severe bleeding as evaluated by a clinician, or severe organ involvement. And that could be multiple organs, including the liver with raised transaminases, the central nervous system with neurological fallout and impaired consciousness, and myocardial or other failure of other organs. To the left of the screen is dengue, various aspects of the dengue definition or classification. On the very left, we've got probable dengue with a history of exposure, potential exposure to dengue through either residence or travel to an area where there's transmission. And then from clinical criteria, it's fever with 2 or more of the following, including nausea, vomiting, and exanthema, aches and pains, tourniquet test positive indicating thrombocytopenia, and leukopenia, or the presence of any warning signs. And the warning signs that were included as of 2009 guidance were abdominal pain or tenderness, persistent vomiting, clinical fluid accumulation, mucosal bleeding, lethargy or restlessness, enlargement of the liver more than 2 centimeters below the costal margin, and an increase in hematocrit concurrent with a rapid decrease in platelet count. And the importance of these warning signs is that the presence of any warning signs should alert the clinician that the patient does need to be strictly observed from a medical standpoint and requires intervention to prevent progression to severe dengue. Having said that, it is not only patients with warning signs that will proceed to develop severe dengue, although those would be in the majority, but even dengue cases without warning signs can progress to severe dengue, which really stresses that clinicians should be aware to forewarn patients or families of patients to be aware of warning signs and to rapidly present for care if those occur. This slide looks at the WHO dengue surveillance case definition from 2009. And as we look at this surveillance case definition and the subsequent outbreak case definitions that were proposed, this is really critical from the public health standpoint to be able to quantify the dengue burden in any given area or comparing areas for planning response actions, including provision of adequate hospital services where those are needed for severe cases. And then also evaluating the impact of interventions and monitoring disease trends. So the wording from this slide you'll recognize from the previous slide, and it's really looking at that exposure history of having lived in or traveled to a dengue endemic area with onset of fever and 2 or more of the symptoms listed. I would like to point out the 2 resources shown on this slide. On the right is the Dengue Guidelines for Diagnosis, Treatment, Prevention and Control, and this was the 2009 edition. As part of that systematic review that I mentioned that is happening globally, those will feed into updated dengue guidelines, which we are hoping to have out as soon as possible, particularly in light of the current dengue outbreak status and the need for this resource. On the left is the dengue outbreak toolbox that's also available on the WHO website. It contains not just the case definitions, but also other helpful resources that can be used for outbreak and surveillance purposes. The proposed suggested outbreak case definition was included in the 2016 Technical Handbook for Dengue Surveillance and Outbreak Prediction and Detection and Outbreak Response. And this again includes the definition for a probable case with or without warning signs, and then also emphasizing the need for strict clinical observations. And then there was a bit more detail around the warning signs themselves, as well as the laboratory criteria for those case definitions. Per the 2009 criteria, there was a division of the laboratory criteria into highly suggestive or confirmed. So highly suggestive would not meet the level of stringent requirements for confirmed, but the highly suggestive included predominantly serologic testing with IgM positive in a single serum sample or a high titer IgG positive in a single sample. And this is important because especially with secondary dengue infections, we may see a very, very low and possibly undetectable IgM response. And then also included in that category in 2009 was the detection of viral NS1 protein antigen. And then confirmed was more direct viral detection, and that remains the best indicator for confirmatory testing through PCR detection, for example, or virus culture. And then also the use of IgM seroconversion in paired sera or IgG seroconversion in paired sera, preferably with a 4-fold IgG titer increase between the 2 sera collected. I don't want you to have to squint to read the tiny writing on this slide, but this shows the PAHO case definition that was issued in 2023. It's very similar to what we've looked at before, with a few key differences that I wanted to highlight. So the PAHO case definition divides cases into suspected cases, probable cases, or confirmed cases. With a suspect case, very similar to what we'd seen before, again, with a history of exposure and then with a fever and the 2 or more symptoms additional to that, but then also adding children with a fever without an apparent focus. And then moving on to the probable case, they that in the PAHO case definition, a single IgM is not confirmatory. That only elevates the case to probable, as does an epidemiological link to a confirmed case. For confirmation, that really requires more stringent laboratory criteria for the PAHO case definition. Again, direct detection of the viral RNA. They included NS1 protein antigen detection as a confirmatory criteria. And then also demonstrated presence of the virus through virus isolation. They also did include a fourfold increase in dengue virus specific antibody titer value with samples collected at least 14 days apart. And then if patients are deceased, then presence of virus can also be detected either by molecular methods such as PCR or by histopathological and immunohistochemical studies.
Another 2 minutes, Ingrid.
Okay, thank you. I'm nearly finished. The last slide over here on the PAHO case classification is that they've divided the classification into dengue without warning signs, dengue with warning signs, and severe dengue. So again, very similar to what we'd seen before. For without warning signs, again, very similar, the criteria for the additional symptoms in addition to the fever, again, nausea and vomiting, the rash, headache or retroorbital pain, that is a bit more specific than just aches and pains in the 2009 WHO definition, as well as myalgia with arthralgia are specified, and then petechiae or positive tourniquet test, as well as leukopenia. For dengue with warning signs, there were a few more specific indications. The abdominal pain that was mentioned is more intense and sustained abdominal pain or tenderness of the abdomen, and then also progressive increase of hematocrit. The last point there that has lost the presence of thrombocytopenia, which is present in the general symptoms, but is not classified as a warning sign here per se. And then severe dengue is consistent with what we'd seen before. So in conclusion, the dengue case definitions and classifications have been progressively refined as more data and systematic review of the evidence has been conducted. I mentioned that we have a large review ongoing at the moment, and it's not just for dengue, but also other Aedes-borne arboviruses. But importantly, the regions do need to consider prevailing clinical presentation of the dengue cases, as well as the differential diagnosis in each region and how that affects the case definition to be able to differentiate dengue, as well as the ability to apply the selected case definition. And really, as a final take-home point, that the standardized case definition should be used across a region to better inform the planning and triage of patients, as well as to determine the impact of countermeasures and articulate what is found epidemiologically from these with the clinical management guidelines as well. And that is my conclusion. I'd like to thank Dr. Raman Velayudhan and Dr. Diana Rojas for their input on the slides, and to everyone for your attention. Thank you.
Thank you, Ingrid. Yes, I suppose it's quite comprehensive. A few participants are requesting for a French version of the presentation because there's a lot of information, very important information, and stepwise method of collating all the criteria to define a case for dengue. So please, we will try to share with them, if not the whole presentation, but really a summary, something also in French, some documentation in French. So we will put it in the participants package as well. But you can see there are some questions and answers. Please, you can address them as we go along. Thank you very much. The next presentation we will have, I see Emily is already open. She's going to talk to us about the pathophysiology of dengue, and we are running out of time, so we really keep to, it's going to be 15 minutes, but if you can help us gain a few more minutes, we'll be grateful. Emily, over to you. And if you have your, if you're listening in English, it's time to switch to the French channel. Thank you. Over.
Okay. Bonjour à tout le monde, je suis Émilie Javel, donc je suis médecin militaire infectiologue en France. Et je vais vous parler de la physiopathologie de la dengue. Alors, je vais passer rapidement parce qu'on a déjà parlé. Donc, la dengue est une maladie vectorielle. Ainsi, dans le cycle, est un transmetteur du virus, alors que l'homme est le réservoir principal du virus. Donc, le cycle se déroule de la façon suivante. Donc, un moustique va acquérir le virus en piquant un homme malade virémique. Il va s'en suivre une période qu'on appelle la période d'incubation extrinsèque, où le virus va s'amplifier chez le moustique. Le moustique va ainsi devenir infectant et va pouvoir transmettre le virus lors de sa prochaine piqûre chez un homme au départ sain. Il s'ensuit une période d'incubation chez l'homme qui est de l'ordre de 4 à 8 jours. Et après ces 4 à 8 jours, l'homme va devenir virémique et va développer les symptômes de la maladie. Donc, dans le cycle de la dengue, il est important de limiter l'exposition entre les moustiques et les hommes, en particulier les hommes virémiques ou non. Cela permet ainsi de réduire la transmission et l'impact des épidémies. Alors, le virus de la dengue, c'est un flavivirus qui a été isolé pour la première fois dans les années 40. Il est constitué d'un génome qui est un brin d'ARN, simple brin qui va être directement transcrit en protéines. On distingue les protéines structurelles du virus, qui incluent les protéines de la capside, de la membrane et de l'enveloppe, et les protéines qui sont dites non structurales, qui vont être des protéines qui ont essentiellement une fonction enzymatique, notamment pour la réplication, la transcription et le clivage des protéines virales. Et ces protéines non structurales vont aussi jouer un rôle dans les interactions entre le virus et le système immunitaire de l'hôte, et donc un rôle dans la virulence et la pathogénie du virus. Alors, on distingue 4 sérotypes du virus de la dengue 1, 2, 3 et 4. Alors, ces sérotypes ont une similarité dans leur séquence protéique qui est de l'ordre de 60 à 75%. Et puis, au sein d'un même sérotype, on va avoir une diversité également génétique et protéique qui va donner lieu à des clades et des génotypes différents. Alors, la diversité génétique, que ce soit entre les sérotypes ou les clades, va être responsable de différences entre les différentes souches virales en termes d'affinité, c'est-à-dire de capacité à se répliquer chez les hôtes du virus, que sont l'homme et le moustique. Donc des différences en termes de potentiel épidémique, et puis également des différences en termes de virulence, c'est-à-dire d'expression clinique et de sévérité de la maladie. Et donc cette virulence, comme je disais tout à l'heure, elle est médiée par des protéines non structurelles du virus, comme les protéines NS2A et NS4B, qui vont médier en fait les interactions entre le virus et le système immunitaire de l'hôte. Alors, le spectre de la dengue est large. La plupart des infections sont asymptomatiques ou infracliniques. Et ensuite, par ordre de fréquence décroissante, on va avoir la maladie classique, bénigne, non compliquée. Ensuite, les formes sévères de la maladie. Et enfin, les formes fatales. Alors, ce qui est important de comprendre dans l'expression de la maladie, c'est que on va avoir au départ une phase clinique typique et la phase aggravative ne va venir que secondairement au moment de la disparition de la fièvre, ce qu'on appelle la défervescence ou la pyrexie. Ça va définir le début d'une phase critique qui se situe à peu près entre le 3e et le 7e jour de la maladie, donc en gros à la fin de la première semaine, et qui correspond au niveau physiopathologique à un moment où la perméabilité capillaire est la plus forte. À partir donc de cette phase critique, l'évolution va être soit vers une maladie bénigne classique, soit vers une forme grave de la dengue. Donc c'est un moment vraiment où il faut être très vigilant, c'est au moment de la disparition de la fièvre. Alors, quelle est la physiopathologie de la forme sévère de la dengue? Donc, en fait, à partir du moment de la défervescence thermique, donc entre le 3e et le 7e jour, on va avoir une perméabilité capillaire importante qui est due au fait que la dengue, en fait, est une maladie de l'endothélium vasculaire, c'est-à-dire une maladie des cellules de la paroi des vaisseaux qui vont à la fois être détruites et qui vont dysfonctionner. Et ensuite, une fois que la phase critique se termine, cette phase critique, elle dure quelques jours, entre 3 et 4 jours, et bien ensuite, il va y avoir une réparation de l'endothélium et on va sortir de la phase à risque de gravité. Alors, cette perméabilité capillaire, de la porosité des vaisseaux, va être responsable, c'est ce qu'on voit sur le schéma, d'une extravasation des cellules, en particulier donc des cellules des globules rouges, ce qui va donner cliniquement une hyperémie au niveau de la peau, c'est-à-dire une peau très rouge, et puis qui va exposer bien sûr au risque de saignement, une fragilité des petits vaisseaux, et puis ensuite des plus gros vaisseaux. On va avoir également une extravasation, c'est-à-dire une fuite de protéines, dont l'albumine. Et donc ça va donner une diminution de la pression oncotique dans les vaisseaux qui va induire une fuite des fluides, des liquides, vers le compartiment extravasculaire. Et donc cliniquement, c'est ce qui va donner les œdèmes ou les effusions des séreuses comme les pleurésies ou l'ascite. Et donc, à l'intérieur du vaisseau, toute cette fuite plasmatique va induire une diminution de la volémie, donc une diminution de la pression artérielle, et puis une élévation au niveau de la prise de sang, au niveau de la biologie, une élévation de l'hématocrite, une hémoconcentration. Et enfin, comme la paroi des vaisseaux est abîmée, comme il y a une dysfonction endothéliale, il va y avoir une tentative un peu de réparation par l'agrégation des plaquettes, il va y avoir une consommation des plaquettes. Et cette diminution des plaquettes va augmenter le risque de saignement. On verra aussi qu'il peut y avoir une destruction des plaquettes par des phénomènes d'auto-immunité qui peuvent être induites par la dengue. Donc la dengue, c'est une maladie en 3 phases. Une première phase fébrile bénigne, puis une phase critique qui correspond à la défervescence thermique, qui va pouvoir s'exprimer soit sous la forme d'un choc hypovolémique, soit sous la forme de saignement, ou encore d'insuffisance d'organes, de dysfonctionnement de certains organes comme le foie, le cerveau ou le cœur. Une fois qu'on est sorti de la phase critique, il est important de noter que la mortalité de la dengue, en l'absence de traitement ou de prise en charge correcte, peut être de l'ordre de 20%. Et sinon, on entre alors dans une phase de guérison, de convalescence, qui est caractérisée chez certaines personnes par de la fatigue. Et surtout, ce qu'il faut savoir, c'est qu'après une infection par un sérotype de la dengue, eh bien, on va développer une immunité durable à vie contre ce sérotype infectant. Par contre, il va y avoir une protection croisée contre les autres sérotypes, mais qui n'est que temporaire, de l'ordre de 2-3 mois. Et ensuite, avec le temps, l'immunité croisée va diminuer, va s'altérer et ne sera pas efficace pour neutraliser les autres sérotypes. Donc, il faut bien noter que l'immunité acquise, elle est spécifique du sérotype qui a causé l'infection. Donc, la gravité de la dengue est liée à la fois à des facteurs de l'hôte et à des facteurs viraux. Donc, les facteurs de l'hôte, ce sont tous les facteurs qui vont influencer la réponse immunitaire ou le risque de saignement. On en parlera demain quand on parlera de la clinique de la dengue, donc notamment tout ce qui sont les âges extrêmes, les comorbidités. Au niveau immunitaire, il y a un fait important qui augmente le risque de gravité, c'est lorsqu'il s'agit d'une infection secondaire, c'est-à-dire lorsque c'est la deuxième infection dans la vie par le virus de la dengue. Cet effet de l'infection secondaire a été montré initialement par des études épidémiologiques qui ont montré qu'il y avait un surrisque lorsque on en était à sa deuxième infection par le virus de la dengue, et en particulier lorsque la séquence des infections, elle est d'abord par le virus de la dengue 1, puis par le virus de la dengue 2, ou encore lorsque l'infection secondaire est due à un sérotype 2 ou 3, ou encore lorsque l'intervalle entre les deux infections est long. Donc tout ça, ça augmente le risque de faire une dengue grave. Alors pourquoi? Pourquoi est-ce que l'infection secondaire est plus à risque que les autres? Eh bien, les mécanismes sous-jacents pourraient être ce qu'on appelle la facilitation de l'infection par les anticorps, qu'on appelle Antibody Dependent Enhancement, ADE. En fait, quand on est infecté par le virus de la dengue, on va développer une immunité, des anticorps qui sont des IgG qui sont vraiment spécifiques de ce sérotype parce qu'ils vont reconnaître des épitopes spécifiques du sérotype. Les épitopes du virus sont localisés dans la protéine E du virus et les anticorps qui reconnaissent ces épitopes ne vont pas ou vont partiellement reconnaître les épitopes des autres sérotypes. Ce qui fait qu'il va y avoir une espèce de réaction croisée, mais qui n'est que partielle et qui ne va pas permettre de neutraliser les autres sérotypes. Il en est de même pour l'immunité cellulaire, c'est-à-dire la production des lymphocytes T, les lymphocytes T mémoire d'un sérotype, lorsqu'ils vont rencontrer un autre sérotype, vont être activés, mais ne vont pas être compétents, ne vont pas avoir assez d'affinité pour éliminer ce nouveau virus. Et donc, le fait qu'il soit activé, ça va induire une réponse immunitaire et une réponse inflammatoire importante, notamment par la libération de cytokines. Et cet orage immunitaire, la libération de cytokines, va aggraver les lésions vasculaires. Voilà. A priori, le fait de faire une infection, une troisième ou une quatrième infection par le virus de la dengue est moins à risque que lorsque c'est une infection secondaire, c'est-à-dire la deuxième infection. Alors, au niveau du virus, donc le virus de la dengue va reconnaître des récepteurs cellulaires et va pouvoir donc cibler des cellules qu'il va infecter. Les cellules infectées par le virus de la dengue sont les cellules endothéliales, mais aussi les cellules immunitaires, telles que les cellules dendritiques ou les macrophages. Et puis, lorsqu'il existe des anticorps qui sont acquis contre un autre sérotype, eh bien, ces anticorps vont pouvoir se lier au nouveau sérotype, mais sans le neutraliser, c'est ce qu'on voit sur le schéma. Et ensuite, le fragment C de l'anticorps lié au virus va se fixer sur des récepteurs à ce fragment C qui sont portés par certaines cellules immunitaires, notamment les monocytes, les macrophages et les cellules dendritiques. Donc, lorsqu'on a une préimmunité contre un autre sérotype, c'est ce qui se passe dans l'ADE, c'est-à-dire dans la facilitation de l'infection par les anticorps, eh bien, on va avoir plus de cellules qui sont infectées à cause de ces récepteurs au fragment FC des anticorps, plus de cellules infectées, une plus forte charge virale, en fait, une plus forte libération de virus et donc une augmentation de la virémie, donc une infection plus forte. Alors ensuite, dans les étapes de l'infection, le virus utilise la machinerie cellulaire de l'hôte pour se répliquer et il va développer également des stratégies pour échapper à la réponse inflammatoire non spécifique, ce qu'on appelle la réponse interféron. Ça, c'est notamment grâce aux protéines non structurales du virus dont je vous ai parlé, les NS2B, 3, 4 et 5, qui vont être des protéines capables en fait de bloquer les médiateurs activateurs de la réponse interféron. Et puis, l'orage cytokinique joue un rôle important dans la gravité de la maladie parce que les cytokines vont augmenter la perméabilité vasculaire en lésant l'endothélium vasculaire. Et donc, ces cytokines vont également être favorisées et libérées en quantité plus massive lorsqu'il y a des protéines NS4B. Et puis, il y a aussi un autre phénomène qui est l'immunité induite par la protéine NS1 du virus. Alors, la protéine NS1 du virus, elle est soit exprimée à la surface des cellules infectées, soit elle est circulante dans le sang de l'hôte infecté. Et l'immunité de l'hôte va induire la production d'anticorps spécifiques de cette protéine NS1. Et donc, ces anticorps vont se lier à la protéine NS1 et faire des complexes immuns. Et ces complexes immuns vont activer le complément et vont donner une cascade inflammatoire qui, là encore, va aboutir à la production de cytokines et à des lésions inflammatoires vasculaires. Et enfin, il y a un dernier phénomène dans l'infection par la dengue, c'est l'auto-immunité, c'est-à-dire qu'il pourrait y avoir production d'anticorps qui sont dirigés directement contre les plaquettes ou contre les cellules endothéliales et qui donc aggravent l'expression de la maladie. Voilà, c'est ma dernière diapositive, c'est pour un peu résumer toute la physiopathologie de la dengue dans sa phase initiale et dans sa phase critique, avec donc plusieurs acteurs, plusieurs composantes. D'abord, bien sûr, la notion d'anticorps préexistants qui vont induire la facilitation par les anticorps, donc via l'infection, en majorant l'infection par le virus des cellules dendritiques et des macrophages. Ensuite, donc, l'activation du complément par la protéine NS1 et les anticorps ciblant la protéine NS1. Ensuite, l'immunité cellulaire, les cellules B et les cellules T. Les cellules T qui vont entraîner la libération de cytokines, les cellules B qui vont produire des anticorps qui vont pouvoir, lors d'infections ultérieures, donner une facilitation par les anticorps, et puis également des anticorps qui peuvent être parfois des auto-anticorps et qui vont détruire les plaquettes ou les cellules endothéliales. Et très important, c'est la libération de cytokines et de médiateurs de l'inflammation qui vont être directement responsables de l'inflammation vasculaire, donc de la destruction et de l'altération du fonctionnement des cellules endothéliales. Et donc ça va augmenter la perméabilité des vaisseaux et donc la fuite vasculaire et le risque hémorragique. Voilà, j'ai fini.
Merci beaucoup, Emily. Thank you very much. I think it's very clear now to everybody how we get to the clinical picture that we see in our health centers. So the last presentation now we'll call on Dr. Konongoi from KEMRI, Kenya Medical Research Institute. He's going to talk to us on dengue diagnosis and differential diagnosis to answer some of the questions that are already in the chat. So over to you, Dr. Konongoi.
Thank you very much, and greetings from Nairobi, Kenya. And I'll briefly speak on diagnosis and differential diagnosis. So as other parts of the African region, I also come from a region that has experienced a good number of dengue outbreaks in the recent past. So Kenya has been experiencing escalating outbreaks since 2013 to date. And we're also surrounded by countries that have been experiencing dengue outbreaks on a regular basis. So it's important for the region as a whole to actually have capacity to be able to detect and respond to dengue outbreaks. So why is dengue diagnosis important? I mean, as from the previous presentations, we really need to confirm suspect cases of dengue. The initial presentation of the cases is usually non-specific, and it's important for us to be able to confirm so that we are able to guide the patient management. Studies have shown that the earlier you are able to detect dengue, the better the chances of the patient actually surviving. Also, it's also important to have dengue as a differential diagnosis. So there are many causes of febrile illnesses in the continent. So dengue being one of them. So we need to have lab capacity to be able to differentiate the different causes of febrile illnesses. Also, in between outbreaks or in between cases, we are also engaged in a number of surveillance activities, both in human and vector populations. And it's important to have lab capacity to be able to confirm dengue. Then also dengue, an accurate diagnosis also informs outbreak response and control. Once you know what agent is responsible for a particular syndrome, you are able to initiate informed control measures. And also it's also important for research and academics, whereby we study various aspects of immunology, pathogenesis, among other things. So an important consideration for all people or labs engaging in diagnostics is the aspects of quality assurance. Basically, we really need to have the right environment to do the right thing, and that the results that we are able to report are actually right. So there are various aspects when it comes to quality assurance in the lab. We need to have staff that are proficient. We also need to have precautions to prevent contamination, and you also need to use the right controls and maybe, if possible, engage in the appropriate proficiency testing panels. So quality assurance is very briefly, it cuts across the board within the testing facilities and also outside the testing facilities. So it starts at the point of sample collection, whereby the physician has to make the right decision in terms of who to sample. Once the sample is collected, we need to handle the sample right. We also need to collect the right sample. The sample has to be transported in the right conditions to the lab. And also once in the lab, we have to do the right analysis based on, for example, when the onset of the disease is indicated, we need also to get the right results and report the results in the right manner. So another thing that we also need to familiarize ourselves is that most of the dengue samples, especially in our region that we test, are actually blood, serum or plasma. So we really need to have the blood collected in the right tube. So for our purposes, we usually insist on either the red capped tubes that do not have any additives added, or the EDTA tubes. So these two tubes are actually ideal for either a virus isolation or PCR or the serology assays. So these are just a general slide on the common mistakes that we usually have when the samples are brought. History is important, labeling is important. We also need to have the sample in the right containers. Quantity of the specimen is a big consideration, because sometimes, given the number of tests that you may have to run to actually confirm the pathogen, you require enough sample. And also, of course, it's critical that the specimens are maintained at the appropriate temperature, all the way from the collection point to delivery in the lab. So from the lab perspective, there are very many factors that actually contribute to the results that we generate. We need to have personnel who are proficient in actually doing that test. The reagents that we use also must be stable, and also the integrity must be guaranteed in terms of storage. Of course, the different types of equipment that we use need to have the appropriate maintenance and calibrations. Then you also need to choose tests that have the right specificity and sensitivity values for us to be able to make a determination. And of course, we need to have the appropriate controls and the appropriate work aids, SOPs included. So I'll briefly go through the diagnostic methods for dengue. When you are choosing a diagnostic test, there are a couple of factors that you need to consider. Why are you doing that test? Is it from a clinical specimen, or is it from, for example, a prevalence study? That will determine what test you're going to use, either PCR or maybe some form of ELISA. The lab infrastructure that is in place will also determine the choice of tests. The requirements for isolation, the requirements for molecular testing, the requirements for serology are usually different. The technical expertise also plays a role. The cost, do you have the resources that you require to do that particular test? And of course, the timing of sample collection is critical in determining which diagnostic test that you're going to use. So there are various targets for diagnosis when it comes to dengue. You can target the virus itself. The options here would be to do either virus isolation or actually the detection of the viral genomic RNA. You can also target the viral products. In this case, you have the NS1 protein, or you can also target the host immune response. IgM assays are preferred, and also, of course, if it's a secondary infection, you can also try paired IgG assays. So this is just a graph to remind us that how a host responds to an infection has implications on the kind of test that we choose to be able to make a determination on whether dengue diagnosis. So basically, after the date of onset of the virus, you'll have viremia for about, for example, 0 to 5 days. Then it goes down by day 10. Then all these aspects are different aspects that you can actually exploit to be able to decide which test is more appropriate at that point in time. So virus culture, so these are the diagnostic methods. So traditionally, it's a gold standard, but of course, it's being rapidly replaced by real-time, reverse transcriptase PCR, since dengue is an RNA virus. And the specimens that are required are specimens that need to have been collected within the acute phase, between day 0 to 5 from symptom onset. So there are various cell lines that are available whereby you can culture. We have insect cell lines, which are more adaptable. We have different mosquito cell lines commercially that are available. We also have mammalian cell lines, the viro cells, the BHK21s, and which are a bit less efficient, but they still work. The only drawback with cell culture is the fact that you have to have the right facility, and also it takes time, an average of about seven days. So once you observe the cytopathic effects in your cell culture, you still have to reconfirm whether the growth is due to dengue or any other agent. So you still have to do maybe immunofluorescence assays or RT-PCR for confirmation. In some facilities, they also do lab animal inoculation. whereby you can actually use suckling day-old mice or mosquito inoculations. Again, the limiting factors here is you have to have the right infrastructure, you have to have the right personnel, and turnaround time is also an issue. And mostly this is, isolation is usually used for characterization or reagent production. So nucleic acid detection, PCR, highly sensitive. Again, the turnaround time is hours as compared to days in virus isolation. Then it just follows the normal PCR steps, whereby we have the nucleic extraction and purification. We have various methods for this. We have the commercial kits, we have the automated systems. It all depends on the facility and the region, which is followed by nucleic acid amplification and visualization of the amplified product. Depending whether it's a conventional PCR, you can do the gel electrophoresis, or if it's a real-time PCR, you can actually get your CT values and you're able to determine whether you have dengue or not. And it's also important, once, whichever protocol that you're using, you have to target the genomic regions that are specific to dengue. And then PCR is also the advantage, apart from the quick turnaround time. We also have multiple platforms and also multiple protocols that can either be singleplex or multiplex. So you're able actually to detect many agents at the same time, but you can also test for the 4 dengue serotypes at the same time. The only drawback, of course, is the issue of resources and cost. And there's a tendency for PCR to occur, especially in our region, in centralized testing facilities due to facility and equipment considerations. Serology, it can be direct or indirect, whereby we are looking at either the antigen itself or the antibodies produced during the viral infections. And we have multiple tests available, both commercial and in-house in various parts of the region. So antigen detection is a common test that is used, whereby you're targeting the NS1 and for both primary and secondary dengue infections. And there are multiple antigen kits that are available commercially. The only drawback, of course, it does detect the acute phase of the infection, but it's not able to give information on serotype. So for IgG, for IgM, again, it's a common test that we use. The only drawback, again, we have to be careful and cautious in interpreting these results. IgM is known to linger for days to months. And also there is also that problem of cross-reactivity with other flaviviruses. So usually for IgM results, it's usually important to, if possible, to confirm using a second sample to observe any increase in antibody titer. But the most common method of confirmation is the use of the PRNT, plaque reduction neutralization assays, which sometimes are not routinely done in most of our labs. IgG results, not really diagnostic as such, but it can be used especially for secondary infections, whereby you have to have 2 samples and look for the 4-fold increase in IgG titers. So then we have the rapid diagnostic kits, basically these lateral flow assays that are usually come in cassette forms, and they are quite popular and widespread in different regions. The advantages is they can actually be used at the point of care, basically as a rapid test. They require minimum training. They do not require electricity. And also they also use minimum amounts of patient sample. And they've come a long way. Although they still have sensitivity and specificity issues, they can actually detect either antibodies or antigens, either individually or in combination. So the advantages of serology and the different types of ELISAs, they are quick and relatively inexpensive. They're ideal for limited resource settings, and we have multiple commercial options available. Of course, the disadvantages is you still have to reconfirm results that are generated through serological assays. And if the sample is collected too early during the acute phase, maybe the antibody responses have not yet started, so you may get false negatives. And also you're not able to get any serotype information, which is important, especially for surveillance purposes. So of course, combined approaches, we have multiple assays available because the infection stages vary. So in most algorithms in different labs, it's important to combine both RT-PCR with IgM detection. Even for the rapid kits, there are quite a number of combined assays whereby they combine NS1 with IgM or IgG. So this is just, I'll not go through this. This is just a dengue testing algorithm from PAHO for a reference. So it's something that you can actually access and be familiar with. So for differential diagnosis, again, we come from a region that has multiple causes of febrile illnesses. So it's usually very challenging to determine what exactly it is, given that we have restrictions in terms of the type of diagnostic assays that we are able to do in our settings. So there are very many important considerations. Malaria tops the list, leptospirosis, rickettsial diseases, other viral causes, for example, flavivirus, fever, Zika. The list is pretty big. Measles and other hemorrhagic fevers. So here in Cambridge also, I mean, we have this capacity at the Center for Virus Research, whereby we use a number of algorithms, whereby we do antigen detection, virus culture, and PCR, and we also have capacity to do whole genome sequencing for characterization and discovery. In addition to that, we're also able to do entomological surveys, and we have access to a BSL-3, insectary, and lab animal facility. So these are just pictures of our facility. So in conclusion, I mean, I think that given the changing epidemiology and the changing geographical range of dengue and also the vector, it's important. Lab testing is key in informing timely detection and characterization, and also in informing dengue surveillance. And this, well, for all labs involved in testing, I think consideration of multiple testing options is important to be able to enhance detection. And self-sufficiency, we need to be self-sufficient, either as countries, as regions, as a continent, in testing capabilities, which is a great asset in response. And we also have to look out for each other and basically create opportunities for capacity building and technology sharing in the region. So those, I just want to thank my fellow lab members, the Ministry of Health, and all our partners and the webinar organizers for the invite. Thank you.
Thank you so much, Dr. Konamgai, for keeping on time, right on time. It leaves us just 10 minutes and a lot of guidance you have provided with other presenters on how to structure and strengthen the dengue control and prevention programs. So we have already 6 hands up. We will invite the participants to unmute themselves. If they can't unmute, the organizers will help us unmute. We will begin with, I've seen the first name is Bankoro. Please just, each of you has basically 1 minute to ask your question, and we will try to answer them together. And the presenters are going to take notes and answer at the end. So, Bankoro. Can you unmute him or her, please?
She can unmute herself or himself.
Okay. Please go ahead, unmute. Great. Yes, go ahead, please.
Yeah, he said there is no question.
No question. Okay, we go to the next person. Maniga Dudu. The hand is down, so we take the next one. Desire. Fitouan. Please unmute yourself, Desire. This year, are you able to? Okay, we'll keep going down, and anybody who can speak up, just unmute yourselves, please. Claudian. Claudian Adibonyo.
Hi, everyone.
Yeah, please go ahead with your question in 1 minute.
Yes, thank you. My question was for the previous session. I don't know if it is possible to ask it now.
Just ask the question and then we'll see how to respond. Most of the presenters are still connected.
So thank you very much. My question was for Dr. Chan. The question was in French. So Dr. Chan, comment régler le problème de la sous-estimation des cas réels et des cas non déclarés? Parce que vu les chiffres, beaucoup de citoyens font la dengue à cause peut-être du dépistage pas forcément accessible, on n'a pas les chiffres. Donc cela se passe et parfois même ça se confond, les symptômes se confondent au paludisme. Donc comment est-ce que vous pensez qu'on peut corriger cela? Merci beaucoup. Thank you very much.
Merci, c'est bien noté. Thank you. Manika?
Oui, bonjour.
1 minute, s'il vous plaît.
D'accord, bonjour. Merci de me donner la parole. Donc, ma question s'adresse à Dr. John. Alors, récemment au Niger, j'ai entendu qu'il y avait une petite épidémie, si on peut le dire comme ça, de la dengue. Bon, entre-temps, voilà. Entre-temps, donc, quelque temps après, ça a disparu. Maintenant, j'aimerais savoir, d'après le sondage qu'il a eu à faire, est-ce que cette épidémie était vraie et s'il y a eu des moyens donc, de diagnostic utilisés? Voilà. Et aussi, la seconde question, vu que cette dengue-là, elle est présente dans le monde depuis 1960, comment se fait-il qu'il n'y ait pas un vaccin qui a été donc élaboré depuis? Voilà. Et actuellement, le vaccin qui est présent, c'est comme vous l'avez dit, c'est vraiment temporaire, c'est-à-dire qu'il y a un risque de réinfection. Maintenant, comment on peut lutter contre ça? Comment faire cette riposte-là? Merci beaucoup.
Merci. So a question on vaccine efficacy, I think there's also some on the chat who will address that. Next person, Claudine, you want to unmute yourself? Or Justin? Justin, vous voulez parler 1 minute? Justin, we'll move along. Rachel Ado, can you unmute yourself and ask your question? 1 minute. On va continuer, hein, si vous ne pouvez pas. On va passer à Debrichu. Can you unmute yourself? Unmute yourself, please, and ask your question. Anyone who can unmute themselves, please ask your question so we can gain time.
So thank you. I have another question for Dr. Limbazu.
Go ahead, please. 1
It is-
minute.
it is
And ask just-
about- yes. Thank you very much. It is about which test is more appropriate for the diagnosis. I didn't get it. I lost for a moment. Thank you.
Very important. Thank you. Next person, please. If your hand is up, please just unmute yourself and talk. Oui. We have just 2 more minutes for the questions. We can't hear you very well, Balima. We move to the next person. Just unmute yourself and ask your question, please.
Ok. Alors, vous me recevez?
Oui, une question, s'il vous plaît.
Voilà. En fait, je voudrais comprendre pourquoi.
Allez-y, on vous écoute.
Hello, can I talk?
Yeah, he's been muted. Okay, go ahead, Professor. Go ahead, talk.
Yeah, thank you for the presentation. I just wanted to know what the plans are for how about countries where dengue is not routinely tested? So what happens?
Good. Thank you. It's well noted.
Un changement brusque de comportement des moustiques qui cause la dengue.
Docteur Balima, vous pouvez reprendre. On vous a perdu depuis 30 secondes.
Ah, ok. Je disais que au Burkina Faso, nous avons vécu avec les moustiques tigres pendant longtemps sans qu'ils nous causent la dengue. Bon, même s'il y avait, c'était vraiment des cas sporadiques. Maintenant, à l'heure actuelle, on n'a pas compris pourquoi subitement, sans qu'il n'y ait, bon, peut-être un changement climatique ou quoi, on a constaté que subitement le pays se plonge dans une épidémie de la dengue sans vraiment raison.
D'accord.
C'est pour cela, bon, je ne sais pas ce qui explique vraiment ce changement brutal de ces moustiques-là.
OK. On va revenir sur vous. Voilà, merci. Merci.
Merci.
Je pense qu'on a fait des évaluations là-bas, donc on va vous répondre de façon. Next person. I'm seeing so many hands. Please, we have just 1 minute for the last questions. Just unmute yourself, ask your question before we pass over the mic to the presenters for answers. Anybody? Asmera, Mamadou, I'm seeing hands up. Few more seconds.
Okay.
Yes,
Okay.
go ahead.
Okay. We need to know about the efficacy of the vaccine. As the dengue is endemic in our country, so we need more information about the vaccine, its availability, its efficacy. Is it one-shot vaccine? Does it prevent from reinfection? More information about the vaccine.
Okay. Yeah, so that's the third question on the vaccine.
Yeah, thank you.
Next person. I think we are getting out of time, so we will now stop. You can put your questions in the chat, and we will give the few additional minutes that we have for this webinar for today to the presenters. I hope they have noted the questions. I can help them if need be. So over to you. We have Ingrid, Emily, and Lunongoy. Yes, please.
Should we go in that order?
Yes, please.
Okay.
Let's go ahead.
So I'll just quickly touch on a couple of points that around the really relevant question about the countries where testing is not done, just speaking from the epidemiology and surveillance side, and also from the kind of global perspective with the dengue IMST, although certainly Dr. John would be able to speak better from the African regional perspective. But we have been working with the respective regions just to get a better assessment of what the needs are for laboratory test availability. Part of the difficulty that we have is we don't have, specific recommended RDTs, for example, from WHO side. So trying to get consolidate the information that is available for evaluations and performance assessments that have been done, and Dr. Lambaso would be better be able to speak to the specifics of the lab aspects, but we are that is clearly a very big need, particularly in countries where they don't necessarily have sophisticated laboratory capacity. So not just within the African region, but for example, in the Western Pacific, in the Pacific Island countries, we often have country situations where they're very, very rudimentary laboratory capacity, and trying to make those tests more available is really critical, because without that, we have so many kind of clinically overlapping diseases that it's very difficult to see what's going on with that. So we are trying to mobilize that from the global standpoint. And then, yeah, in terms of the emergence or apparent increase in cases as well, I think it's a combination of factors. I think the spreading of the vector is certainly an issue. We know that with Aedes-borne arboviruses, movement of viremic humans is usually what transports the virus into new areas, and that also through travel and trade impacts that. And then also just recognition, clinical recognition and laboratory testing. As those happen, we keep on detecting new areas that are now detecting dengue for the first time, or maybe new increases just because the testing is being implemented as well. So that was all from my side. Thank you.
Thank you so much, Ingrid. Emily, something to add? And anyone can take on the vaccine efficacy question as well, and then we'll end up with John.
Yeah, sure. In the chat, there is a question about if we can have dengue several times. Yes, you can have 4 infections by dengue virus in your life. You can be infected by each serotype 1 time, because after the infection with 1 serotype, you will develop a lifelong immunity. And this immunity is not enough to protect against the other serotype. And so this is also linked with the efficacy of the vaccine. The question about the vaccine is important because we said that having pre-existing antibodies against 1 serotype may induce a severe infection with another serotype. So if you have a vaccine against dengue, you need to have a vaccine which is highly efficace against all the 4 serotypes. Otherwise, you are at risk to have a partial immunity against some serotype. And so if you are infected with 1 serotype you don't have efficient antibodies against, then you are at risk to have a severe infection. And this is the theory of the antibody-dependent enhancement, meaning that an increased immune activation can be associated with a severe infection, a severe disease. So the vaccine must be tetravalent. It must be highly effective against all the 4 serotypes and at all the ages. These are some issue with the vaccine that they may not be with the same efficacy according to the age of the subject who are vaccinated, and also according to the serotype of the virus. So that's very important.
Mm-hmm. Thank you. Thank you, Emily. Lonongoi, you had some questions on what is being recommended. What's the best test for that dengue? Very precise question. Can you come on that again?
Yes, thank you. Yes, thank you. I mean, the most ideal test, resource allowing.
Hello? We lost you. Hello, Konongoi. Okay, we lost him, but probably he will come back on the chat. And dear participants, we really have much more to discuss in the following days. I think we'll come back to some of these topics, but let John just say a final, address a few of those other questions before we wrap up. John. You're muted, please. Unmute yourself.
Thank you so much for having me. I will go straight to the point and giving some highlights. First of all, maintenant, on parle des moins amis de la fièvre dengue. On dit dengue. On ne dit pas dengue fever. To avoid confusion, because how Dr. Rahman said, 80% of cases don't have a fever. So it's may loss. This is why it's very important to not continue to talking about dengue fever, but just dengue, because it will have an impact even on case definition. And our case definition in Afro region is aligning a little bit on what Pao did. We are talking about suspect cases, and among suspect cases, it's important, as Ingrid say, to understand why we are highlighting warning sign, because when we are in the community and we identify according to suspect cases with or without warning sign, it will help us to take action and to avoid death going through severity. So this case definition highlighting what suspect cases with without warning sign and with other, it's really key and very, very important. It's able to understand. So please, dengue and not dengue fever, it's important to understand, to highlight, and to disseminate case definition with warning sign. It's important for some action and so on. Secondly, I would like quickly to say where we are not reporting testing dengue. The most important, this is why it's important to conduct the risk mapping. Il est important de faire la cartographie du risque. Nous l'avons fait et puis nous allons diffuser, mais vous pouvez le faire au niveau pays également. Ça tient compte de quoi? Ça tient compte de la densité des AEDS, de la vulnérabilité des personnes, mais aussi de la capacité des pays, pour résumer un peu. Et donc, avec l'évaluation du risque de la dengue dans chaque pays saura s'il est vulnérable ou non, s'il a des capacités ou non à faire la faute. Et donc, on peut dire que là où il y a une forte densité, il y a un risque élevé, bien sûr, les mesures vont être prises. Et donc, quand vous avez bien fait l'analyse du risque, vous allez mettre en place, vous allez adresser les gaps. So, when you complete your risk mapping, you will be identified area of improvement, and then you'll be taking action. So it's very difficult to base on just one thing. It's recommended to talk about. Sous-estimation des cas. Là où on a sous-estimé, Dr Raman l'a dit, il faut, comme on a des faiblesses dans la détection, comme on n'a pas suffisamment de tests et autres, il faut utiliser les outils que l'OMS va mettre à votre disposition pour estimer. Comme ça, chaque fois que vous allez commencer à rapporter des cas, vous savez combien c'est en bas de l'iceberg. Et puis, vous allez vous dire que notre système de surveillance n'est pas capable de détecter ce qui nous... C'est pourquoi l'exercice de l'estimation du burden, de l'ampleur est important. Et il y a des outils pour ça. Dr Dorothy et tous les restes, Dr TLB et tous nos experts qui sont en ligne vont distribuer cet outil-là. C'est important pour voir le gap qu'il y a. Combien de cas nous ratons chaque fois que nous faisons, et puis pour réactiver. Et bel et bien, nous avons une épidémie de dengue au Niger. Et le dernier cas a été rapporté le 19 décembre de l'année passée. Et donc, c'était une épidémie qui a été documentée, mais qui a été contenue d'une certaine manière, et il faudrait important de pouvoir l'indiquer. Et je vais terminer par le dernier comment. C'est par rapport à l'importance de pouvoir documenter l'exercice qui s'est fait dans les différents pays. On parle de quel est le test, le meilleur test. Bon, notre collègue s'est déconnecté, mais parmi les choses que l'OMS utilise, c'est commander les tests qui sont duo. Ça veut dire quoi? Qui est capable à la fois, rapide, hein, je prends les tests rapides qui utilisent qui est duo, ça veut dire il peut détecter le NS1, l'antigène, il peut détecter l'antigène, donc ça fait double. Au lieu d'utiliser un test qui est juste IgM ou bien IgG et puis juste NRC1, il y a des tests duo et qui sont pratiques, qui couvrent. Parce que si vous ne détectez que l'antigène, pas l'anticorps, il y a des limites à ça par rapport à si l'infection est aiguë ou comment, il y a beaucoup de choses qui vont. Et donc, la moindre des choses, nous, ce que nous pouvons recommander pour le niveau bas du système de santé, d'utiliser les tests rapides qui ont une sensibilité et spécificité acceptables, qui peuvent couvrir l'antigène et l'anticorps, c'est l'idéal. Et puis, le reste de l'effort, nous allons les concentrer sur les laboratoires de référence avec les tests appropriés pour les PCR et culture. Ça, c'est un autre niveau. Mais si nous avons très peu de moyens, c'est à la communauté et c'est avec des tests duo que nous allons essayer de le faire. C'est ainsi que dans la définition des cas que nous sommes en train de développer, comme Dr Ingil l'a présenté, Tout ce qui est suspect se base sur les signes. On dit suspect. C'est warning sign, c'est-à-dire signe d'alarme ou pas. Tout ce qui est test rapide, nous classifions vers le probable. Et nous disons confirmer lorsqu'il c'est PCR ou c'est culture, pour vraiment résumer de manière simple comment il faut comprendre la définition de quoi, pourquoi il est important de highlight que parfois on n'a pas de fièvre et comment on peut bien améliorer le système de surveillance. Merci beaucoup, Dr. Achou. Je termine par là. Merci.
Merci beaucoup, Dr. John. Thank you so much for that good summary in terms of how to define the cases. And the message is really to improve our surveillance systems. And whatever surveillance system you're dealing with, whatever test you're using, you have to know whether it's suspected, it's a probable case, or it's a confirmed case using a PCR and more sensitive tests. So thank you very much for your participation for today. We will continue the discussions tomorrow. It's a 2-hour webinar. We apologize for getting a little bit overboard. We want to thank our panelists, our speakers, our presenters. They will still be joining, some of them, in the days ahead to answer your questions. Please, presenters, answer the questions in the Q&A. We're going to make a collection of them so that we can give feedback to participants. We hope to see everybody again tomorrow. We've just started on the epidemiology and case definitions. We're going to engage the clinical management of dengue. And please, we want to again thank the organizers of the webinar, especially the incident management team of AFRO for doing this job. And we hope that will improve on the organization, on the logistics for all those people who couldn't get interpretation, who could not get sound. We'll try to improve tomorrow. Thank you, and see you tomorrow at 12 GMT +1 or GMT 11 a.m. Have a good afternoon.